Okay, we're right back. I'm doing these in sequence. And so let's pick right back up again, starting with joint movement here. So this showed up in chapter 10 as a method, and we looked at this a lot in chapter 8, as well as chapter 10 in the Essential Science book. So range of motion is the finding. This is how far a joint should be able to move. And we assess that through joint movement, whether we move the person or they move themselves. And then each of these joint movements can be positioning for a muscle test, which then can, depending on what we find, whether we're looking at a hypermobility or a hypomobility based on what we find with the joint, or some sort of alteration in tone where we want to either stimulate a better contraction or want to inhibit one, with muscle energy type techniques to elongate. The joint movement is the foundation of what we are doing to both gather that data and to provide the intervention. So again, I refer you back to those chapters. And here's another discussion around end feel. And most end feels should be soft. And if they're hard or too loose or grabby, that would be an indication for a potential referral. And then what are we going to do about that? What are our intervention guidelines? Now, all of the joint movement can be done in conjunction with the postural assessment. More commonly, you're moving all the joints when you're doing massage. So it kind of flows in with the general protocol sequence. So along with this joint movement concept, there are a whole series of orthopedic tests. Oh, there's tons of them. And you can Google that and you can see how many of them that there are. Under scrutiny, the reliability of these orthopedic tests has been brought into question. We use orthopedic tests as a way of screening for referral, much more than we would use it to try to diagnose and then treat. So the ones that are listed here are 4 common areas that would cue us into there's something really going on with the joint or structures adjacent to the joint that we need to possibly have somebody else take a look at. So the box here goes through and describes those, and I would also refer you to a Google search. And especially in physical medicine, osteopathy, a lot of times they don't do as many of these and they'll rely more on a MRI type exam. And it's because they're not as reliable as we would think. But in the past, when these were created, they had value because they could at least narrow down what might possibly be going on with stuff. So there is value in these. There's Tendons test. There's straight leg test. There's anterior and posterior drawer on the knee. There should not be movement in there. Same with the ankles. and also extension type tests that would screen for something going on in the vertebral area. So we'll practice these in the classroom. And then if you want to know more about them or want them more explanation, like I say, there's a lot you can find on the internet on these. So now we've got the tools that we're looking at for assessing joint function, which is going to include the bones, the internal structures of the joint itself, including the articular cartilage and the connective tissue structures, inclusive of ligaments and tendons in the joint capsule, the give in there, the ability for the joints to spin and roll, called joint play. That information. So here is a sequence here. If somebody is coming in and saying, it hurts here in my shoulder joint, then these are the questions we would want to expand on to learn more about that. And then again, with our intervention guidelines, first and foremost, we are looking for potential need for referral, then adaptation for cautions, and then potentially intervention that could help with the symptoms and or the function. Now, palpation is the biggie because massage is palpation. And so we will practice this a lot in class along with the other assessments. This is divided into, it's arbitrarily divided into layers of palpation. And so you will reinforce this by classroom instruction, but it's nice to go back and read through this. So first we've got this near touch palpation, and then assessment, and then intervention guidelines, and then we have palpation of the skin, hot, cold, wet, dry, rough, smooth. And if we find something, again, always look for what's working well. That moves nice. That's not hot. This is really good. In addition to finding areas, well, that seems a little warm to the touch, or that is kind of sticky when I try to move that. Don't always be looking for what's wrong. Always look for what's working well. You can get a lot of information about the general health status through the hair and the nails. And then the superficial palpation, the superficial connective tissue, the skin is tightly adhered to that. And here we're looking, I call it the wetsuit. We're looking at density, we're looking at resilience, and then we're looking at slip and slide on the deep fascia. Lots of times this is what people will think of when they're thinking of the myofascial techniques. And then we're looking at fluid flow here with palpation of the vessels and the lymph nodes. And so now the anatomy becomes essential because you got to know where these vessels are in order to palpate them. So with the pulses, for example, if we're going to feel the pulses at the foot, we want them to feel even on both sides. If for some reason they don't, then that could be an indication for a referral because we don't know what's going on in there. Then when we get to palpation of the muscle tissue, now we talked about this in chapter 9 in Essential Science. So we can palpate the contours, but if we really want to know that we're on a muscle, usually it's a group. It's almost impossible to palpate an individual muscle. But if we're looking at a functional unit, like this one happens to be knee extensors, if we have them perform the action, extend their knee, that is going to cause these muscles to concentrically contract and pull. When they do that, they'll harden up and push up a little bit. And so we can relate accuracy of the palpation to the joint movement that was produced. And this has to be active, it can't be passive. Person has to move it. Then we can also try to translate the joint function or the muscle, try to translate and slide one muscle layer over top of the other. So this is showing how, in this case, the elbow flexors, if I have them contract that, if I have them assume the movement and then I push away with a little bit of resistance, that's going to load that muscle and it's going to make it firm up for me. And this also then is a muscle test too. Now the palpation of the tendons is going to be for many of the muscle type structures around the jointed area. And sometimes there's mechanoreceptors in there that can gauge for integrity of movement in that area, and sometimes those get a little confused. They tend to respond pretty good to something called inhibitory pressure plus movement. You find the area, you put just enough pressure on it to see if it recreates the familiar sensation, and then you either have the client move that joint through the range or you do it. Palpation of the deep fascia is getting trickier now, but you can feel grooves where functional muscle units are wrapped together, and then another functional unit like the adductors of the leg with the knee flexors of the leg or the hamstrings. Though each of those functional units is wrapped separately in deep fascia, and then there's where they lie together, there's a little groove, and then through that groove runs a lot of your major vessels and nerves. And so you can kind of feel that. These lines give you a really good idea of how these deep fascia compartments are organized on the body. Now, I don't encourage you to use a deep stripping pressure along these lines because they do indicate where there is a little valley where the nerves and vessels are running, and you don't, those tissues do not like a lot of compression or shear that you would get if you're stripping through those. At the same time, if these kind of get stuck to each other, then you're going to have some restricted movement. And so sometimes the translation back and forth is enough to free that up. So here's an example of that. This is I'm using a broad-based compression to provide some space in between the calf and then the lateral muscles in through there. Now, in Chapter 8 in Essential Science, it leads you through precise palpation of joints. The landmarks, the whole thing. So go back to that chapter and either use the read to me feature or read it and palpate at the same time and review all of that. And then we also get into a discussion here on long levers and short levers and one jointed muscle and two jointed muscles. And in the biomechanics chapter in Essential Science, we talked about inner unit and outer unit, or intrinsic and global muscles. And that information is going to help you make decisions about what function is going to be interfered with. So if it is a short lever, one jointed muscle like brachialis here, then that muscle does produce movement, but it's also important with stability. So how I would assess that, I would have them move the elbow through the joint, and then I would also apply some resistance with that. And then I have to pay attention. Most of these are underneath the long lever. So they are more prone to setting up these trigger tender point areas that I might be able to find through palpation and reproduce a symptom that is bothering the client. And then we have the palpation of the bones. We can get that mostly around the joint areas, especially with the bony landmarks. But there are something called periosteal pain points, and it's where the tendons actually insert into the periosteum of the bone. If there's some pulling in there or some shearing back and forth, that can become inflamed and can be quite painful. And we typically don't want to rub a lot on that. Now, maybe, and when it's not in the acute phase, some deep transverse friction might be helpful, but not when it's in the acute phase and it's exquisitely tender and got some other signs of inflammation. Typically, when we're palpating the abdomen, we are not super attentive to the viscera, the stomach, the liver, the intestines, that sort of thing. But we should be aware if there's anything that feels particularly hard in there, or if there's something that is painful, or you too easily can feel the aortic pulses in the abdomen. And so that would be a potential indication for a referral. More likely that we're looking at this area in terms of core stability, which is not just the abdomen, it's the whole girdle area from the lumbar dorsal fascia and the lumbar spine all the way around, and then how it stabilizes into the thorax, the ribs and the thoracic cage where the lung and heart and all that is at. That's what we're looking at, and we want to make sure that we massage that area thoroughly and try to normalize the function there. In addition, there is a way we can also take a look at supporting peristalsis and colon function. And then we have a rhythm to ourselves. The most obvious one is the heart rhythm, the pumping of the fluid, the blood, and then our breathing rhythm. And breathing intrinsically ties us into our autonomic nervous system. So there's a lot of homeostatic regulation involved with that. Breathing is a voluntary function. We can actually regulate it and control it, but it's also an autonomic function. So we're going to want to look for a nice breathing rhythm and the functional movement that goes on with that. And a common thing we'll find with especially our stress and pain management outcomes is that the breathing is not supporting parasympathetic rest and renewal. It's kind of locked up, and it's perpetuating the sympathetic autonomic nervous system fight or flight response. And interestingly, massage can do a lot to just free up the mechanics of the bellows in through here. It's massage here on the back, but more it's massage on the sides and in the front. So this is kind of a summary here on a palpation exercise that goes through and gives you all the different things that you learn to pay attention to. And then we get into the specifics on muscle testing, strength testing. These are pulses here. And how to do that, and how to do that safely so that we're not overpowering that. And then the ability to get a sense of what's happening between the communication between agonists and antagonists. Now, the really good chapter for this to perfect this is chapter 10 in Essential Science, in the activities in the second half of the chapter. So we also get into this idea of muscle group interactions, which we also talked about in chapter 10 of Essential Science, and the idea of sequences of contraction and relaxation in order to provide for smooth movement. And that's what this segment is about. And it gives you pictures of those assessments. And they're the same types of pictures that you will find in Essential Science. And there are videos on Canvas for you related to chapter 11 that do a really good job demonstrating this. We also have to stop and consider different kinds of muscle fiber function and what various muscle structures do if they have a predominantly white fiber or red fiber, fast twitch or slow twitch fiber. So, you know, the nice thing about this particular thing is that it tells you, if you're going through this, what's the normal firing, how do you do it, what commonly is messed up with it, and what is a person going to feel. And this is what somebody will come back in saying, I have my back right in through here, and it sort of even hurts down into my knee. So practice doing this. We will work with this in class, but repetition, repetition. Repetition, 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 repetition. So these postural muscles are the ones that tend to shorten. Remember we talked about caves and hills? They tend to shorten under strain. And then reciprocally, these phasic muscles may be inhibited a little bit. And so by understanding those relationships, and in chapter 10, we talked about, in Essential Science, we talked about upper and lower cross syndrome as an example of this, and then also the kinetic chain. So these are balance points. These are areas where we move. And so we primarily will concentrate the soft tissue application in between these blue lines. And it gets right into the idea of functional movement as opposed to individual muscles. This tippy pole thing here gives us an idea of what happens when we start to have distortion. And so if something is short, something else is going to have to be long. Now, this is a theoretical concept. This is a way of thinking. And you can kind of assess for this with postural distortion. But this also might be resourceful compensation. So don't rush in and try to reverse it. But the general rule is that you concentrate methods that elongate and reduce tone in the cave, and you use symptom management methods plus some exercise on the hill. And into this functional biomechanical assessment within Essential Science. So this is where we try to figure out just how much the body is attempting to adapt to these more mechanical structures, the joints and the bones and the muscles and the soft tissue, and how that's affecting the whole. So we have first degree, second degree, and third degree. These are the actual shifts and changes in the structures, which is going to then labor or increase strain in function. And that's the stage 1, stage 2, stage 3. So we can do really good as massage therapists autonomously with first degree and minor second degree distortion that is stage 1 and the beginnings of stage 2. But as it might progress, or a person comes to us more complex into second degree or third degree issues, then we're more and more likely to need to be involved with an interdisciplinary team as opposed to working individually. So here are some generalized intervention guidelines here that I have been mentioning, and they're bullet pointed for you here. Here's a real good example of a visual assessment and what you can see and the various movements that you're going to want to learn to do. So that should help you. This is a very important table right here that talks about stages of tissue healing and what you would do. Stage 1, acute inflammatory reaction. Stage 2, subacute. Now these stage 1, 2, and 3s are different than the biomechanical dysfunction up there. This is talking about how the body heals and repairs. And then this last part here is going to give us some guidance on how to approach our massage based on the assessment findings. So there is no recipe. It really becomes like a scientific experiment almost, with the massage and interventions being the actual experiment, and the pre and post assessment kind of telling us if what we did worked or not. And you have to be okay with that ambiguity. This little table is pretty helpful. Depending on your goals, excuse me, depending on your outcome goals here, it will guide you on what a specific assessment you would use. And you can see that functional mobility has the most complex assessment process. And it's interesting because if you look at justification for evidence-informed practice, back in Chapter 5 in Fundamentals, relaxation, well-being, and stress management have the most support, with pain management following, but not as much for functional mobility. And a lot of the manual therapy, not just massage as a manual therapy, but all of them, like structural integration and chiropractic and physical therapy and all of that, those are all manual therapies. We spend a lot of time trying to figure it out, and there's the least evidence to show that much of anything that we do really makes much of a difference. That's a reality check. So you make your best educated guess with a care/treatment plan. And then you do your reassessment to see if something managed to be of benefit. So here's a review on that decision-making process and some case studies to help you practice that. And you will want to do those. And I'm probably going to ask you to write your own. And in addition, Chapter 16 in this textbook, there are 20 case studies that cover the most common conditions and complicating factors that you are going to encounter. And I strongly, strongly, strongly encourage you to work your way through all of those case studies. And of course, we know now how we handle the end of chapter features that help us with retention. This is the same gait muscle testing protocol that you would find at the very end of chapter 10, along with the firing sequences in Essential Science. And the reason why it's moved here is because it's long and it broke the chapter up too much. So that's why this is here. And there are videos that support this. I strongly suggest you pay more attention to the pictures. Than, it can get a little thick reading it. And do use your Evolve resource, or all your Evolve sources for HEC students are on Canvas for you. Referencing, and then your end of chapter questions. And in my experience on the MBLEX exam, these are the type of questions that you will find. And here are, in the chapter, here are the answers and rationales for you, as well as them being on the Evolve site, as well as some of the other workbook activities. And there's also a case study here that goes through an entire process with a variety of session notes that will help clarify. So that takes us through the Do It chapter, or Do It unit. And the next chapters that we will explore are involved with what often is considered advanced work or beyond the basics. I think that with realistic expectations, you can absorb some of this information sufficiently enough for entry-level practice that it can help you make some good decisions, especially around adapting massage to common populations and or conditions. So that is how we are gonna progress. So you're gonna wanna listen to these multiple times. That's what's nice about having it recorded, is that you can go back and chunk it up and look at it multiple times, which is a good thing.